This video talks about the agents of subcutaneous and systemic mycoses. We're going to start by talking about the agents of subcutaneous mycoses first. So general characteristics, they affect subcutaneous tissue. So we have the superficial, which is just on the surface of the body, the cutaneous, which affects the layers of the skin, and then we have subcutaneous, which can affect all the way through to the skin to the underlying layers, the fat tissue, or underneath the layers of the skin. Usually a result of traumatic implantation of foreign objects into the deep layers of the skin, permitting the fungus to gain entry into the host. In other words, you get a cut, you get stabbed with something in the garden, and this gets deeper into the skin. Causative agents, organisms are typically found in soil or decaying vegetation. Infections may be grouped by either the disease process they caused or the causative agents involved. Chromoblastomycosis, also known as varicose dermatitis and chromomycosis. Chromoblastomycosis occurs worldwide but is common in tropical and subtropical regions of Americas and Africa. In the United States, most cases occur in Texas and Louisiana. Agents would be listed below. The primary one that you'll have to be able to identify is Fialophora varicosa. Clinical manifestations: common subcutaneous mycosis, chronic infections of the skin and subcutaneous tissue, and develops over a period of months or more commonly years. It is mostly asymptomatic in the absence of secondary complications such as bacterial infections, carcinomatous degeneration, and elephantiasis. Lesions are usually confined to the extremities, often the feet and lower legs, and are a result of trauma to these areas. Lesions frequently appear as varicose nodules that may become ulcerated and crusted. Long-standing lesions have cauliflower-like surface, brown, round sclerotic bodies, which are non-budding structures occurring singly or in clusters, are seen in tissues. These sclerotic bodies reproduce by dividing in various planes, resulting in multicellular forms. Occasionally, short hyphal elements are seen. The presence of sclerotic bodies is diagnostic for this disease. Males are predominantly infected, possibly indicating a role of sex hormones in the disease development. Again, I'm highlighting Fialophora varicosa. Laboratory diagnosis: isolates are identified on the basis of characteristic structures, such as arrangement of conidia and the manner in which the conidia are born. Organisms causing chromoblastomycosis are darkly pigmented. Growth is moderate to slow, and colonies are velvety to woolly and gray-brown, olivaceous black. So this shows Fialophora varicosa. You can see the spores being released from here. Here's another image of the spores being released in a slightly different pattern. Another picture. And when you look at this, you can tell it's Fialophora because you have flask-shaped phyllides. So here's that. You can see flask-shaped. Cup-shaped collarette, which is up at the top. And balls of oval Fialoconidia. So these are the oval-shaped conidia, the spores that are being released. Species are not differentiated by colony morphologies because they all produce similar colony characteristics. Molecular approaches such as ribosomal gene sequencing provide accurate identification to the species level. And here's a table that discusses microscopic morphology. Eumycotic mycotomas. These are subcutaneous and cutaneous tissue infection at the inoculation site, at the site where the skin has been cut or punctured. Swelling and exudate straining to the skin surface. They can be caused by fungi or bacteria. So there's actinomycotic mycotomas. Those are caused by bacteria. Although clinical manifestations are similar for both types, the cause must be determined because therapy for each is different. Obviously, if it's a bacterial infection, we'd want an antibiotic. Whereas if it was a fungal infection, we would use an antifungal treatment. Mycotomas occur primarily in tropical and subtropical areas, but are also seen in temperate zones. The disease is endemic in India, Africa, and South America. Although mycetoma is an uncommon mycosis in the United States, the following species are the most commonly incriminated agents: Cedosporium, Fusarium, a few others, and exophiala. So the three that I've highlighted are the ones that are important for identification for this class. Direct microscopic examination of the granules collected from draining lesions immediately differentiates the eumycotic from actinomycotic mycostomas. Actinomycetes has branching filamentous rods. Eumycotic infections have hyphal elements. So here's the picture of the bacteria. You can tell they're super tiny, and those are rod-shaped bacteria. So that would be the bacterial form of this. And then here you can see much larger hyphal elements. So that would be the fungal one. Pseudosporium. Previously thought that Pseudosporium was an anamorphic state of S. boydii, but the molecular characterization revealed that S. boydii and S. apiospermum are different species. S. boydii produces oval conidia. The telomorph form is noted formation containing ascospores. This phenomenon occurs in fungi that are homophalic, the ability of a single organism to undergo sexual reproduction without a mate. This isolate grows rapidly and produces colonies that are white to dark gray on potato dextrose agar. Opinions regarding this fungi differ in relation to it being hyaline or phaeoid. Something that I do want to note for this entire presentation is that for identification of fungi, you do not need to memorize the colony morphology or the color shape surface of the colony as it's growing on the plate. You only need to be able to identify the microscopic structures. So you'll be looking at pictures of the slides and you'll be looking at the microscopic structures. So this is what Pseudosporium looks like. Pseudosporium, additional pictures. So you should be able to identify the microscopic structures. You will not have to identify it on a plate. So subcutaneous phaeohyphomycosis. If I don't say that slowly, I'll never be able to get that out. A mycotic disease caused by darkly pigmented phaeoid or dematiaceous fungi, fungi that have melanin in their cell walls. Phaeohyphomycosis was coined to distinguish several clinical infections caused by phaeoid fungi from these distinct clinical entities known as chromoblastomycosis. In tissues, these fungi may form yeast-like cells that are solitary or in short chains or hyphae that are septate, branched, or unbranched, and often swollen, irregular, or beaded. Here's a table showing some of those. The ones that we kind of focus on in this class: Alternaria, Cladosporium, Curvularia, Exophiala, Phyalophora are the ones. So here is Exophiala and a couple more pictures of Exophiala. It's similar to Phyalophora, but no collarette. So you don't see that like cup-shaped toward the top. So when you're looking at pictures of these, you're not going to see that cup-shaped collarette. Or if we go back to Phyalophora verrucosa, here you can see this cup-shaped collarette. And here's another picture. So the cup-shaped collarette, no cup-shaped collarette. It just kind of comes to a point. Sporothrix schenckeii. Sorry. Clinical manifestations, most common presentation, lymphocutaneous sporotrichosis, nodular and ulcerative lesions, worldwide distribution, found in soil and decaying vegetative matter, associated with gardening, rosebush thorns, any type of puncture to the skin while you're gardening. Laboratory diagnosis, direct examination of the tissue might reveal members of S. schenckeii species, complex as small cigar-shaped yeasts. Microscopic examination from culture reveals thin, delicate hyphae bearing conidia developing in a rosette pattern at the ends of delicate conidiophores. Dark-walled conidia are also produced along the sides of hyphae and may be more readily viewable than rosettes in mature cultures. Because members of this complex are dimorphic, cultures are examined at 22 and 37C. These fungi grow well on most culture media, including those containing cyclohexamide. Colony morphology at 22C can be variable. At this temperature, colonies are often initially white, glabrous, and yeast-like. Demonstration of dimorphism is important for the identification of these species. To induce mycelia conversion to yeast, the fungus is inoculated onto brain-heart infusion agar, supplemented with sheep red blood cells, and incubated at 37C. The formation of yeast colonies may be required for several subcultures, or may require several subcultures. Complete conversion seldom occurs, but a portion of the colony will develop yeast-like cells. So dimorphism, it's important to be able to differentiate which species are dimorphic from which ones are not. Dimorphic means that at one temperature, typically they grow at the yeast form, and at another temperature, they grow at the mold form. So if they're growing in body temperature, 37C, they're going to be more likely to grow the yeast form, while room temperature or colder, they'd be more likely to grow the mold form. So here's the yeast phase and here's the mold phase. This is a more characteristic picture of what sporothrix would look like on the exam. And here's another picture of that. So budding yeast cell, delicate branching hyphae, numerous conidia in a rosette. So moving on to agents of systemic mycoses. Clarification of the term systemic. So although the term systemic generally refers to the organisms described here, it must be understood that any fungus in any immunocompromised host has the potential to become invasive and disseminate. So pretty much any organism in the immunocompromised can be systemic. The ones that we're talking about specifically in this slideshow can do it even in a healthy individual. So the morphology of the system dimorphic conversion of yeast or spheral form occurs when it is incubated at 35 to 37C on enriched media with increased concentration of CO2. Each agent has a fairly well-defined endemic area. The diseases are contracted generally by inhalation of infectious conidia. All laboratory procedures to recover and identify these must be performed in a biological safety cabinet. So these are our four: blastomyces, histoplasma, coccidioides, and paracoccidioides. These are our big guys. So the dimorphic ones, thermally dimorphic, are listed here. And there's some ecology, clinical disease, and then tissue form. So starting with blastomyces, it's most prevalent in middle-aged men, presumably of occupational and recreational exposure to the soil. Patients with primary infection have flu-like symptoms and most are asymptomatic. When primary disease fails to resolve, pulmonary disease may ensue, which leads to cough, weight loss, chest pain, and fever. Progressive pulmonary or invasive disease may follow. Results in ulcerative lesions of the skin and bone. In immunocompromised patients may experience multiple organ systems involved and rapid death. Cause is blastomycosis, also known as Gilchrist disease in North American, blastomycosis Chicago disease. Occurs primarily in North American parts of Africa. B. dermatitis is endemic in Mississippi and Ohio River basins. B. helicus is primarily in the West. Several species are now recognized. Specimens of choice would be tissue or purulent material in cutaneous skin lesions. Direct microscopic examination would show large spherical refractile yeasts with double contoured wall and buds connected by a broad base. Potassium hydroxide or calcofluor white may be used to enhance yeast cell detection. In the mold phase, conidia are borne on short lateral branches that are ovoid, dumbbell-shaped and vary in diameter. Microconidia resemble other fungi and are thus not diagnostic. So this is the yeast phase on the left and the mold phase on the right. And here's another picture, a diagram of blastomyces dermatitis. Laboratory diagnostics, we are going to correlate the microscopic structures to culture characteristics, so colony morphology. And then we look for that dimorphism. The mycelial phase of these fungi require confirmatory ID, typically DNA probe or sequencing. Because of low sensitivity and specificity, antigen detection methods are generally not used. Coccidioides, considered as the probable most virulent of all human mycotic agents. Two very similar species infect humans, C. immitis and C. posidacei. Mode of transmission, inhalation of only a few arthroconidia produces primary coccidiomycoses. Types of clinical infections, asymptomatic pulmonary disease and allergic manifestations. Toxic erythema, erythema nodosum, multiforme, arthritis. Primary disease in these cases usually resolve without therapy. Confers a strong specific immunity to reinfection. Primary disease symptoms would be fever, respiratory distress, cough, anorexia, headache, malaise, myalgia. Disease might progress to secondary coccidiomycoses, which cause nodules, or cavitary lung disease, and other progressive pulmonary disease. In about 1% of this population, single or multi-system dissemination follows. They reside in a narrow ecological niche, the lower Sonoran life zone, areas of low rainfall and semi-arid conditions. Highly endemic areas also include San Joaquin Valley of California and certain parts of Arizona and southwest Texas. Endemic areas outside of the United States, northern Mexico, Guatemala, Honduras, and parts of the South America. Geographic locations, you can see the different species and where they would be found. After inhalation, the barrel-shaped arthroconidia, which measure that measurement, round up as they convert to spherules. The spherules produce endospores by this process, known as progressive cleavage. Direct spear examination secretions may reveal the spherules containing the endospores. Caution must be exercised when diagnosis is made by histopathological means only. Direct antigen detection methods are limited. Fertile hyphae arising at right angles to the vegetative hyphae produces alternating hyaline arthroconidia separated by disjuncture cell. When released, conidia have an annular frill at both ends. As the culture ages, vegetative hyphae also fragment into arthroconidia. Variety of mold morphology produced at 22 degrees Celsius. Initial growth, which occurs 3 to 4 days, is white to gray, moist, and glabrous. Colonies rapidly develop abundant aerial mycelia, and the colony appears to enlarge at a circular bloom. Mature colonies usually turn tan to brown to lavender in color. So this shows the spherules. Those are more round shaped. And here's the arthroconidia. These two pictures are more commonly used in on the qualifying exams. So you're probably going to encounter the arthroconidia a little bit more than spherules. And this is kind of characteristic of what it would look like under the microscope. Histoplasma. Histoplasmosis is known as reticuloendothelial cytomycosis, cave disease, spelunker's disease, or Darling disease. Histoplasmosis infection is typically acquired by inhalation of microconidia of Histoplasma species. The microconidia are phagocytized by macrophages in the pulmonary parenchyma. The host with intact immune defenses, or in the host with a normal immune system, the infection is limited and usually asymptomatic, with only sequel being as calcification in the lungs, liver, and spleen. Heavy exposure may result in acute pulmonary disease. In immunocompromised, it's progressive and potentially fatal disseminated disease is possible. Other manifestations, mediastinnitis, pericarditis, mucocutaneous lesions. Worldwide distribution, highest endemicity, Ohio, Missouri, Mississippi River. Organisms reside in soil with a high nitrogen content, particularly in areas with heavily contaminated with bat and bird guano. So histoplasma is typically associated with bat and bird guano. That's why it's called the cave disease, because you've got a lot of caves, bats living in caves, which can spread this. Careful examination of direct smear preparations of specimens of histoplasmosis frequently reveals small yeast cells and similar histoplasma species, particularly in infections seen in immunodeficient hosts. So this shows pictures of monocytes, tissue, and bronchiolar lavage. Sometimes the blastoconidia of Candida glabrata looks similar. Mycelium can be useful in detection, otherwise direct antigen detection in serological procedures, and a combination of DNA hybridization system and DNA sequencing can be used. So here's another picture of the large tuberculate macroconidia. And here we go, we've got the macroconidia pictured here. So this is your typical picture that you would see. It kind of looks like a virus. It looks like a circle with a whole bunch of spikes sticking out of it, kind of like a rhinovirus. But this is what that would look like under the microscope. Paracoccidioides, this is the causative agent of paracoccidiomycosis. A chronic progressive fungal disease. Pulmonary in nature, infection is usually unapparent and asymptomatic. Subsequent dissemination leads to ulcerative granulomatous lesions of the buccal, nasal, and occasionally gastrointestinal mucosa. Concomitant striking lymph node involvement is evident. Dissemination to other organs, particularly the adrenals, occurs with compromised host defenses. Endemic to Central America and South America. Highest incidence are in areas that typically humid and experience high rainfall with acidic soil conditions. Direct microscopic examination shows budding yeast cells, multipolar budding at the peripheral resembling a mariner's wheel. And here's a picture of that. So you can see the budding yeast cells on multiple portions here. And here's a bunch of different pictures to show you. So this picture here, these here, these would be more indicative of that ship's wheel appearance. Mold morphology, microscopic morphology, and then the dimorphic ability would be used in diagnosis. So in agents of opportunistic mycoses, so these guys usually only cause infection in the immunocompromised or otherwise weakened individuals, and they're important to note because there's a lot of them are going to cause very similar infections, but there's some distinguishing features of each of these that you can look at and distinguish them like microscopically. So saprobe and saprophyte. Those terms describe free-living microorganisms in the environment that are typically not of concern in humans. The line between these two terms has been increasingly blurred due to the growing number of people with defects in their immune systems. Ideal points of saprophyte infection, surgical wounds, skin and nail bed infections, or severe respiratory infections. Members of this group of fungi are found worldwide, often associated with decaying vegetation. Mucorales. Mucorales, a common environmental isolate associated with soil and plants. They contain or contaminate grains, breads, and fruits, most often associated with infections of the sinuses, lungs, and skin of the immunocompromised. Diabetics is a significant risk factor for these infections. Clinical significance, rhinocerebral zygomycosis, and disseminated disease. So mucor, rhizoids are absent in most species. The sporangia frequently remain intact as opposed to rhizopus species in which sporangia typically collapse. Mucor grow rapidly and form cottony, dirty white colonies that become mousy brown to gray with age. Rhizopus, the most common zygomycete that causes human disease, typically in diabetic patients with ketoacidosis presenting as rhinocerebral mucormycosis. May be refractory to treatment and may be recovered from almost any source. Rhizopus is our common bread mold. So having molds around the immunocompromised is very dangerous. The rapidly growing have erect sporangiophores terminating in dark sporangia. At the base of the sporangiospores are brown rhizoids. Sporangia are typically fragile, do not easily retain when making the slide culture preparations, resulting in an umbrella shape structure at the end of conidiophores. So this is a picture of that, and you can kind of see they've collapsed a little bit during the process. And here is a picture of them intact still. Rhizopus is one that you had to identify when we were going through basic microscopy or basic skills for mycology. Syncephalastrum, rarely implicated in human disease, but has been documented in cutaneous infections. Found in soil and decaying vegetation, microscopically erect sporangiophores. Each sporangiophore has a large columella. Isolates are sometimes confused with aspergillus on initial examination. Colonies are rapidly growing and are initially white and become gray with age. So this is a picture of a typical syncephalastrum, which you'll have to identify. Septate and hyaline saprobes. So aspergillus, there's 4 main species that are pathogenic. Route of transmission, typically inhaled. Mortality from infections remains high. The immunocompromised host, particularly in neutropenic individuals. The most frequent cause of disease in bone marrow transplant recipients, in addition to other transplant recipients and those with cancer. Infection is initiated following inhalation of conidia. In the lung air spaces, conidia germinate into hyphae, which invade the tissue, including blood vessels. Pneumonia-like symptoms are common. The infection easily spreads hematogeneously, and it's not uncommon to find multi-organ system involvement, including the brain, liver, heart, and bone. Also trigger allergic reactions and are common causes of sensitivities to molds. Other frequent presentation is that of so-called fungus balls in the lungs of agricultural workers who routinely are in contact with fungal conidia from environmental sources. Chronic pulmonary aspergillosis may occur in patients with structural damage to their lungs caused by other diseases, including tuberculosis and sarcoidosis. Appearance is described here. Sometimes it's easier to just look at pictures. The one you will have to identify is this one right here for Aspergillus fumigatus. Colony appearance is not something that you'll have to identify, but it's listed here. And moving on to Fusarium. So Fusarium is frequently seen in mycotic keratitis. 2006 outbreak in the United States, more than 100 individuals wearing soft contact lenses. Specific contact lens solution was infected, occurred typically in patients who wore contacts continuously without removal for several days at a time. In bone marrow transplant infections, or recipients with infections caused by Fusaria, the mortality rate approaches 100%. Unless a patient regains some cell-mediated immunity, mortality is certain because of the ability of these fungi to grow and continue to invade despite antifungal therapy. Patients present with high fever, possibly disseminated skin lesions, in some patients, fungemia. Fusarium species can be recovered in blood culture systems. Care should be taken when reviewing positive blood cultures because isolates typically appear yeast-like on initial recovery. Abundant macroconidia with fewer microconidia are produced by vegetative hyphae. Macroconidia, banana, or canoe-shaped. These are very easily distinguishable for Fusarium. And we're going to move ahead to what Fusarium looks like under the microscope. So this is like super blown up. This is looking at it under an actual slide that I prepared myself, so you can kind of take a look at what that looks like. And here's another picture where it's probably stained with some type of iodine solution, but you can see them here. This is going to be more of your typical picture that you'll identify. And they do look like little canoes or little bananas. Geotrichum, pulmonary disease in immunocompromised. Microscopic evaluation reveals abundant arthroconidia formed from vegetative hyphae that occur singly or may be branched. Colonies appear white to cream and yeast-like, can be confused with trichosporon. Occasionally, aerial mycelium forms produced colonies that resemble those of coccidioides. Penicillium. Because many penicillium are inhibited at 37C, They do not frequently cause infection. Most reports of disease involve chronic fungal sinusitis, ubiquitous in nature, worldwide distribution. Conidiophores are erect, sometimes branched, with medullae bearing one or several phyllades on which oval to oval conidia are produced. So here you can see those branching up here. And here's another picture that will be used on exams in the future. Scopulariopsis. This is nail specimens implicated in pulmonary disease and immunocompromised. You can see that there's like these chains of balls that kind of branch up. So you have hyphae, and then you'll have these ball-like structures kind of branching straight out. Septate and phaoid saprobes. Alternaria, primarily implicated in chronic fungal sinusitis, often misdiagnosed, and patients are treated for bacterial sinusitis. This is a picture of alternaria. And you'll have to identify alternaria by the microscope. Cladosporium, infrequent cause of disease, but primarily recovered as laboratory contaminant. Infections are typically confined to the sinuses. And it describes the colony appearance. And this is what that looks like under the microscope. Cladosporium. And this is a more typical species of what you would see for Cladosporium. And some more of these. So this would be a really good picture of it. Curvularia. Again, chronic sinusitis. This is a picture of curvularia. And this is our kind of typical LCB prep of it. So big thing for this one would be identification of all the species listed, and then knowing the main disease causing ones and what disease they cause.